Morning, everybody. Today's class is on classification of anemia and its investigations. Before going to the classification, let us see about normal hematopoiesis. Hemo refers to blood cells and poiesis refers to development or production of these cells. The word hematopoiesis refers to production and development of all the blood cells. Erythrocytes, erythropoiesis, leukocytes, leukopoiesis, thrombocytes, thrombopoiesis. Depends on three important components, that is the bone marrow stroma, the hematopoietic stem and progenitor cells, and the hematopoietic growth factors. The stem cells have an extensive proliferative capacity and they also have the ability to give rise to new stem cells. That is, one stem cell gives rise to another stem cell. That is called as self-renewal. It has the ability to differentiate into any blood cell lines. So, the growth and development of the bone, they grow and develop in the bone marrow. And the bone marrow and the spleen form a supporting system called the hematopoietic microenvironment. So the stem cells have got a self-renewal capacity. They grow and develop in the bone marrow and the spleen. There are types of stem cells. There are pluripotent stem cells, the myeloid stem cells, and the lymphoid stem cells. Active hematopoiesis is found in children throughout the axial as well as appendicular skeleton, whereas in adults it is found only in the axial skeleton and proximal end of the appendiculars. Hematopoiesis takes place in the yolk sac, the liver and spleen, and the bone marrow. In the initial months, up to 3 months, it is in the yolk sac. Following this, the liver and the spleen till the time of birth, and then it is taken over by the bone marrow. Stem cells migrate to the bone marrow where hematopoiesis starts and all the different cell types are formed. When required, the yellow marrow will be replaced by red marrow. The liver and the spleen resume the production of these cells, and the cells will multiply the production by about 6 times. That is called as extramedullary hematopoiesis. So if it occurs within the marrow, it is intramedullary. If it occurs in the liver and spleen, it's called as extramedullary hematopoiesis. So we have the pluripotent stem cells, then the myeloid stem cells and lymphoid stem cells. And from the myeloid, we get into erythroblast, megakaryoblast, and the different leukocytes. There are so many growth factors on this, the colony stimulating factors, erythropoietin and thrombopoietin. Interleukins, stem cells give us progenitor cells that may be multipotential, bipotential, or unipotential. They differentiate into precursor cells, are also called as maturing cells, and then the terminally differentiated mature cells. For erythropoiesis, we have proerythroblast, basophilic erythroblast, polychromatophilic erythroblast, orthochromic erythroblast, and late starting from a proerythroblast, early normoblast, intermediate normoblast, late normoblast, and then one step prior, that is reticulocyte. This is the penultimate stage of the precursor cell. It is having only a fine network of reticulum, that is the remnant of RNA, and in the neonates this count is about 2 to 6%, and otherwise in adults it is 0.5 to 2.5%. This is how the reticulocytes look when we do a new methylene blue stain. Mature erythrocyte is a biconcave disc. It does not have a nucleus, and about 1/3 of it is filled with hemoglobin. The granulopoiesis, we have the granulocytes, that are neutrophils, eosinophils, and basophils, and only major cells are seen in the peripheral. They also start their process from a blast cell, that is a myeloblast, proceeding to a promyelocyte, myelocyte, metamyelocyte, a band cell, and a neutrophil. Blast form less than 1% of the bone marrow cells. They have prominent nucleoli. They are rich in myeloperoxidase, which helps in their identification. The killing function is first to be operational only in the neutrophil cell line, so myeloblast is non-functional. Promyelocyte also forms 1 to 5% of the bone marrow. Nucleoli begin to fade. And in the myelocyte, we have production of the granules. Myelocytes form 10% of the bone marrow cells. Nucleoli are not visible. The secondary granules start appearing, and the cells acquire motility, and alkaline phosphatase also begins to concentrate. The different cell lines for granulopoiesis, eosinophil, basophil, neutrophil. Metamyelocytes form about 20% of the cells in the bone marrow, but they are not seen in the peripheral smear. Neutrophils, this is the band forms, form about 40%. They are almost mature cells. They do have tertiary granules and about 6% of circulating WBC. Neutrophils have got many shaped nucleus, so they are called polymorphonuclear. About 50 to 70% of circulating cells are the neutrophil. Function phagocytosis and pyelocyte. To summarize, the granulocyte maturation starts from a myeloblast, proceeding to a promyelocyte, myelocyte, metamyelocyte, stab form or a band form, and a segmented neutrophil. The monocyte macrophage cells also start from monoblast, proceed through monocytes, and in the tissues they become macrophages. Monocyte is the largest cell in the peripheral smear, and the function is mainly phagocyte. So the monoblast proceeds through monocyte, promonocyte, monocyte, and into the tissues it becomes a macrophage. Lymphocytes begin their development in the thymus and the bone marrow, and the other places, other organs are the spleen, Peyer's patches, tonsils, and adenoids, the lymph nodes. Lymphocytes are found to circulate throughout the body, in the peripheral blood, and in the lymph. They are again short-lived or long-lived. We have memory cells. The function of lymphocytes is to produce antibodies and lymphokines. This is to summarize the cells with their origin from a stem cell into a myeloid stem cell and a lymphoid stem cells, and thereby into the different cells. So, in the blood cell, total cells in the blood are the red blood cells, the platelets, myelocytes, the monocytes, neutrophil, eosinophil, basophil, and the lymph. Lymphocytes form about 20 to 40% of the circulating cells. Thrombopoiesis begins with megakaryocytes, the megakaryocyte undergoes endomitotic division and then gives rise to platelets. So in summary, normal hematopoiesis is necessary for survival. It is under the control of multiple factors. Normal bone marrow environment is necessary for a normal hematopoiesis, and decreased production leads to anemia. This picture gives us a summary of the different cells. Hemoglobin, we have different types of hemoglobin. HbA1 consists of alpha to beta 2 chains. HbA2 consists of alpha to delta 2 chains. HbF is alpha to gamma 2 chains. We have to know something about the blood cell indices to know the different types of anemia. So we have indices in the form of mean corpuscular hemoglobin concentration, mean corpuscular hemoglobin, and mean corpuscular volume, and the red cell distribution width. Reticulocyte is an important diagnostic tool. Knowing the count of this is important, as in case of anemia, there is reduction in the RBCs. So we would like to know on the production of the RBCs, which we can make out through the reticulocyte count. It is a reflection of the amount of effective red blood cell production taking place in the bone marrow. The RBC lifespan is about 100 days plus or minus 20 days, whereas the reticulocyte is seen 1 day in peripheral blood. The normal value is 0.5 to 1.5 per 100 red blood cells. You can stain the blood with new methylene blue stain, and this is how it looks as a reticulocyte formation. We'll go into the different types of RBCs that are seen according to the variation in the shape. So there can be acanthocytes in a patient as seen in anorexia nervosa. You can see the teardrop cells, RBCs in the form of teardrops. These are sickle cell anemias when there is a defect in the hemoglobin. You can see them in the form of acanthocytes in the peripheral blood. There can be elliptocytes. They may be in the form of schistocytes or broken cells. There will be target cells that are seen in some conditions like hemoglobin C disease. There may be stomatocytes where the central pallor is in the form of a elongated slit-like area. There may be spherocytes in circulation, or it may be in the form of fillet formation in case multiple abnormalities in the hemoglobinization. There might be hypochromic cells. We might see some inclusions in the form of Pappenheimer bodies, Cabo rings, Haynes bodies, or even Hobble-Jolly bodies. So here you can see the different inclusions. The A depicts the Cabo rings. The C is the Haynes bodies, and the B is a Hobble-Jolly body. Now coming to anemia proper, we should know what is anemia. Anemia is a decrease in the RBC count, hemoglobin or hematocrit values, and with normal reference for the age, altitude, and gender. So anemia can be, anemia is now a decrease in the RBC count, and we cannot measure the RBC count directly, so we interpret the reduction in the RBC count in the form of reduction in hemoglobin or the reduction in the hematocrit values. And this is with a reference range in relation to age, altitude, and gender. The hemoglobin values vary for different age and different gender. Decrease in any of this is called as anemia. True anemia is a decrease in the RBC mass and in the normal plasma volume. Whereas pseudo or dilutional anemia is normal RBC mass, but the plasma volume has increased. As in case of pregnancy, there is increased fluid, but the RBC mass remains the same, so it may be a pseudoanemia or a dilutional anemia. Or in case of a congestive heart failure, RBC count is normal, but the plasma volume is hemoglobin and hematocrit values may be. This condition is called as a pseudo or dilutional anemia. This is to represent a normal and a pseudoanemia. So in case of a normal, the plasma volume is about 50% and the red cell mass is about 45%. So it's between 45 and 55. In case of true anemia, the volume is reduced because the red cell mass is reduced. The hematocrit is about 30% and the rest of it is plasma only. Whereas in case of pseudoanemia or in case of hemodilution, there is increase in the plasma cell volume, but the RBC mass remains the same. Coming to a diagnosis of anemia, it can be made based on the history of the patient, physical examination, the different signs and symptoms, and the laboratory findings. This definition emphasizes the differences one should expect when evaluating probable anemia in the different age. Anemia may also relate to the level of hemoglobin the individual normally possesses. In an adult male, usually maintains a hemoglobin level of 16 grams and over a period of days, if it is reduced to 14, it is considered significant, even though both the values are within the normal range of an adult. In case of anemia, signs of accelerated bone marrow erythropoiesis will. Due to hypoxia, the kidney will produce erythropoietin, which is responsible for stimulating RBC production in the bone. The marrow becomes hypercellular due to marked increase in the RBC precursors, which is called as erythroid hyperplasia, and the MC ratio. The normal MC ratio is 3:1, and here the erythroid cells will be. Nucleated RBCs may be released into the blood circulation along with the outpouring of reticulocytes. So we can see the nucleated RBCs coming into the circulation when there is anemia and increase in erythropoietin. NRBC number correlates with the severity of anemia. More severe the anemia, the body tries to compensate by increasing the production of RBCs. So, the nucleated RBCs tend to come into circulation. And increased polychromasia is seen on right staining of the blood sphere because of the increase in the number of circulating reticulocytes. It has already been mentioned prior that reticulocytes are one step prior to the mature RBCs. So the nucleus has been extruded, but the RNA is still there and the cells take up a polychromatic state. So here, this is a nucleated RBC with the nucleus, and this is the reticulocyte without the nucleus, and this staining of this is polychromatophilic. That is, it is two colors. It is pink and blue together, so it is called as polychromatophilic RBC. Medullary and extramedullary hematopoiesis. So, if the demand exceeds the bone marrow capacity, the RBC production may be taken over by extramedullary sites like the liver and the spleen. So, if it occurs in the bone, in the axial skeleton, it is called as medullary hematopoiesis. If it occurs in the liver and the spleen, it is called as extramedullary hematopoiesis. In case of anemia, there is increased stimulation to produce, so we may at times see in some cases extramedullary hematopoiesis. Physiologic response to anemia is ability to adapt to anemia depends on the age and cardiopulmonary function. The rate at which the anemia develops, so bone marrow can compensate easier if the onset is slow and based on the underlying disease. Capacity or the ability to adapt to anemia depends on the age, the cardio and the pulmonary function, the rate at which the anemia develops, and underlying disease. What are the symptoms of hypoxia? So, decreased oxygen delivery to the tissues or organ may cause vague symptoms like fatigue, faintness, weakness, dizziness, headaches, dyspnea, poor exercise tolerance, or leg cramps. Anemia may be because of reduced RBC production, may be because of blood loss, or it may be because of hemolysis. Whenever there is a reduced RBC production, this may be because of specific causes like deficiency in vitamin 12, reduction in iron, or a stem cell defect like aplastic anemia, or any genetic defect. This in turn gives rise to reduced RBC production, that is anemia. Or there is a road traffic accident or any cause where there is acute blood loss, which leads to anemia. Third possibility is of hemolysis. The RBCs are broken down, leading to anemia. Whatever the cause of anemia, the outcome is inadequate oxygen transport, thereby leading to tissue hypoxia. So the various tissues respond in different ways to hypoxia. So there may be fatigability, somnolence in case of brain symptoms, work capacity is decreased, tachycardia is because of the effort of the heart to increase the pumping, or it may lead to pump failure. In lungs, it may lead to dyspnea or a decreased respiratory rhythm. Skeletal muscle may manifest in the form of weakness or fatigability. What are the effects of anemia? Maybe because of decreased blood viscosity, maybe because of hypoxia, maybe because of increased cardiac output, or because of increased workload of the heart. The signs and symptoms of anemia, mainly pallor. So pallor can be seen visualizing the tongue, a pale tongue, is pallor in the conjunctiva, pallor in the palms. There might be glossitis when you see the tongue, and there might be poilonitis. These are the signs and symptoms to be looked for in case of anemia. So pallor is looked for conjunctiva, or you can see the methods of classification in anemia. How to classify anemia? There are different methods by which we do it, different classifying schemes based on the morphology of the cells. So it can be based on the morphology, thereby taking help with RBC indices. Anemia is divided into three groups, or based on the cause and mechanisms, that is the pathophysiology, can be divided into impaired erythrocyte formation, right? Aplastic anemia, iron deficiency anemia, sideroblastic anemia, anemia of chronic disease, microblastic anemia. Here, because of all these causes, there is impaired production of erythrocytes. Second is increased blood loss. It can be acute blood loss or a chronic blood loss. It is increased blood loss. Anemia results when red cell loss exceeds the bone marrow's capacity to increase its activity. Here, the red count is very high, where the bone marrow tries to compensate. The third is increased destruction of the RBC, that is hemolytic anemia. So, whenever the RBCs, the red cells are destroyed, then the bone marrow still tries to increase its activity, so the red count is high. So anemia based on the pathophysiology can be classified into paired erythrocyte formation, increased blood loss, or increased destruction of the RBCs. Based on the morphological categories, the anemia is classified into normocytic normochromic, where anemia is due to decrease the number of erythrocytes. Normocytic normochromic, the indices are normal. The MCV, MCH, and MCHC are within normal limits. We see this type of anemia in case of aplastic anemia of blood loss. Microcytic hypochromic anemia, where the MCV and MCH are reduced. Macrocytic anemia, normochromic anemia, where the MCV is increased. So the causes of anemia may be blood loss and deficiency, infection, RBC destruction, folate and B12. But based on the red cell size and indices, hemoglobin concentration and hematocrit, MCV, MCH, and MCHC, it is divided into decreased MCV, normal MCV, and increased MCV. The decreased MCV is iron deficiency anemia, thalassemia. Increased MCV is in deficient and B12. Normal MCV in case of blood loss. If we know the indices, we can classify them. Again, we have go into details of this. MCV is less than 80 to 100 is the normal MCV. If the MCV is less than 80, causes can be iron deficiency anemia, anemia of chronic disease, thalassemia, or sideroblastic. The MCV is more than 100, it is megaloblastic, non-megaloblastic. Megaloblastic, where it is due to deficiency of folate and vitamin B12. Non-megaloblastic in case of liver disease, alcoholism. The anemias within the normal MCVs spread the reticulocyte count. If the count is less than 3, blood loss, early stage of iron deficiency or aplastic anemia. If it is more, can be intrinsic defect, RBC defect, or extrinsic RBC defect. Intrinsic defect can be due to membrane defects, hereditary spherocytosis, hereditary elliptocytosis, paroxysmal nocturnal, can be related to hemoglobins, where the hemoglobin is abnormal, as in case of sickle cell anemia, due to deficiency of enzymes, that is G6PD or pyruvate kinase deficiency. Extrinsic defect can be immunohemolytic anemias, proangiopathic hemolytic anemia, or related to classification of anemia based on the cause, decreased delivery or red cell. The decreased delivery of the red cells into the circulation can be a maturation defect, the production defect. If it is a maturation defect, it may be because of decreased hemoglobin synthesis. But as decreased hemoglobin synthesis leads on to microcytic RBCs. These are seen in case of iron deficiency anemia, thalassemia, sideroblastic anemia. Is related to decrease in DNA synthesis. Cells are macrocytic, megaloblastic anemia. Related to vitamin B12 and folic acid. Production defect, wherever there is bone marrow injury, decrease in erythropoietin or filtration. Bone marrow injury, all these, whenever there is a production defect, they are normocytic, because the MCV values are normal. The reticulocytes can be normal or low. Whenever there is a bone marrow injury, it is related to bone marrow, related to stem cells, it can be seen in aplastic anemia. If it is due to decreased erythropoietin, it is renal disease. Marrow infiltration can be because of pigment. Increased loss of red cell from the circulation. Whenever there is hemorrhage, it is normocytic, normophobic. Here again, the reticulocyte count is very high in case of hemorrhage, as in case of acute blood loss. Increased destruction of the RBCs. Hemolytic anemia may be hereditary or acquired. Here again, the MCV is almost normal and reticulocyte counts will be. So, to come back to this, the different categories. In case of morphological categories, how it is done is based on the morphology of the cells. The cell is size, that is microcytic, hypochromic, microcytic hypochromic anemia, where the MCHC and MCB are seen in case of iron deficiency anemia, thalassemia, anemia of chronic disease, and anemia. Macrocytic, where MCHC is normal, but MCB is more. High MCB, normal, vitamin B12 deficiency, folic acid deficiency, liver disease, normocytic normochromic anemia, where MCB is normal, MCHC is normal. These are seen in case of acute hemorrhage. Aplastic anemia, where this is a stem cell disorder, where there is disappearance of RBC versus from the marrow. Anemia of chronic disease and hemolytic. So we see these three morphological categories in the peripheral smear. So you have a lymphocyte for comparison, where the RBCs, size of the lymphocytes, the size of the RBC is small, the central pallor is more, lymphocytic hypochromic. Here, lymphocyte is in comparison to the RBCs. RBCs are of normal size in comparable to the lymphocytes. The central pallor is also normal. Example of normocytic normal. Here, you can see the RBCs are much bigger than the size of the nucleus of the lymphocyte. This is the macrocytic anemia. Macrocytic. So in the impaired RBC production, we have abnormal bone marrow leading on to anemia in case of aplastic anemia or myelofibrosis, that is myelofibrosis. Essential factor deficiency, that is iron deficiency, vitamin B12 deficiency, acid deficiency, or deficiency of erythropoietin as in renal disease. Stimulation factor deficiency, where there is anemia of chronic disease, hypopituitarism, or hypothyroidism. In case of hemolytic anemia, we have intracorpuscular defect, extracorpuscular defects. Intracorpuscular, the defect is related to the membrane, it may be related to the enzyme, or it is related to the hemoglobin. Related to the membrane is seen in hereditary spherocytosis or hereditary phagocytosis. Enzyme deficiency, J6PD and pyruvate kinase deficiency. Hemoglobin, the defect in the hemoglobin seen in thalassemia or hemoglobin. Excessive destruction of RBC, that is extracorpuscular. Mechanical factors destroying the RBCs like microinterpathic hemolytic anemia. Chemical or physical causes destroying the RBCs, or in case of infection with Clostridium tetani, antibodies and hypersplenism causing destruction of RBCs. Coming to the investigations, they are hematological, basic chemistry, urine analysis, stool examination, and radiological exam. In the hematology, we have the complete blood count, where you have hemoglobin, hematocrit, RBC values, WBC values, and retic count with differential count and platelet count. So MCB, MCH, and MCHC suggest what type of anemias, and the RTW helps to differentiate iron deficiency. Looking at the peripheral smear, you can see the size and shape of the RBCs, the hemoglobin content, size and shape is microcytic, normocytic, or macrocytic. Hemoglobin content can be hypochromia or normochromia, whether there is polychromatophilia, whether there are any inclusions, whether there is any Rayleigh formation, and whether there is platelet count. In chemistries, you would like to know what has happened to the blood urea creatinine, whether the bilirubin levels have increased. So if there is a destruction of the RBCs, the hemoglobin levels are more, the LDH values are high, proteins may be low. Then if we are suspecting deficiencies of iron, folic acid and B12, we can estimate these different values and make a diagnosis. The urine analysis, whether there is proteinuria, whether there are RBCs in the urine, hematuria may be a cause of hemoglobin anemia, and whether there is any hemoglobin. The RBC, coming to the investigations in general, you see the RBCs, hemoglobin or hematocrit. If it is low, we move on to the indices. If the indices are the lesser side, we go for serum iron, TIBC and ferritin levels. If it is low, that means it's iron deficiency anemia. If it is normal, it is a case of thalassemia. If it is high, it is heteroplastic anemia. If it is iron deficiency anemia, we can treat it. If it is thalassemia, it needs further uh, diagnosis with electrophoresis and high iron, that is sideroblastic anemia. If the MCV levels are normal, then it may be because of blood loss. You go for a retic count. If it is low retic count, it is aplastic anemia. If it is high retic, it is a hemolytic anemia. So we would like to go for further tests to find out the cause for hemolytic anemia. So, and do a Coombs test or electrophoresis and other tests of RBC, evidence of RBC destruction. MCV is high, then we go for folate levels, vitamin B12 levels. If it is low, it indicates the deficiency of B12 or folate. If it is normal, it is non-megaloblastic related to liver disease. Thank you.